Hello everybody. Today we are going to discuss about aortic dissection. Aortic dissection is associated with the significant mortality and morbidity and often requiring immediate intervention. Its diagnosis can be challenging due to multiple and often non-specific ways it can present. It has estimated incidence of 6 per 1 lakh with more than 60% death secondary to aortic dissection diagnosed at postmortem. The management of the acute aortic dissection is dependent on the patient's condition, type of dissection, and its extension. Now about pathophysiology and classification. The aortic dissection describes a tear in the intimal lining of the aorta extending into the media of the wall. Blood flow through this tear leads to the formation of the false passage bordered by the inner and the outer layer of the media. Connective tissue diseases such as Marfan and the Ehlers-Danlos syndrome increases the risk of dissection due to weakening of the media. Other causes include the atherosclerosis, trauma, inflammatory, infective, and iatrogenic condition. Aortic dissection can be classified by their location and the chronicity, with management strategies differing significantly between them. So this is the DeBurkey and the Stanford classification of the aortic dissection. We'll see what is it. So about Stanford classification, this system classifies dissection in relation to their involvement of the ascending aorta. So type A involves the ascending aorta, the arc, and the descending aorta. Type B does not involve ascending aorta and it involves the descending thoracic and abdominal aorta. About DeBurkey classification, this divides the aortic dissection into three types. Type 1 originate in the ascending aorta involving ascending aorta, arc of aorta, and the descending thoracic aorta. Type B involves only ascending aorta. Type 3 distal to the left subclavian artery and further classified as 3A and 3B. 3A is limited to the descending thoracic aorta, 3B extending below the diaphragm. About chronicity, the aortic dissection may also be classified by their chronicity as follows. Acute, which occurring within the 14 days of onset of the pain, subacute occurring between the 15 and 90 days of the pain, and the chronic occurring more than 90 days from the onset of the pain. About diagnosis, aortic dissection may present in several ways and mimic other pathologies, making diagnosis challenging. High degree of suspicion is thus required in patient with the suggestive feature. Think aorta has been recommended as an approach for its early recognition in any patient with severe chest pain by the patient charity Aortic Dissection Awareness UK. A recent investigation conducted by Health Service Investigation Branch highlights many of the challenges faced by clinicians acute aortic dissection. Presentation of the Stanford type A aortic dissection may include severe chest pain, syncope, aortic insufficiency, pulse differential, myocardial ischemia, and neurological signs. Presentation of the Stanford B aortic dissection may include severe chest, back, or migrating pain, distal pulse differential, limb pain, claudication, renal insufficiency, and high blood pressure. Rapid diagnosis is the vital as treatment is time critical. More than 20% of patients with acute aortic dissection die before reaching hospital, with more than 50% dying before reaching the specialist care center. So aortic dissection mortality increased by 1% to 2% per hour after symptom onset. Several investigations can be used to help rule out in and out of aortic dissection, ranging from bedside test to the magnetic resonance imaging. Combining the patient's presentation, risk profile, and the result of relevant investigation are key to making timely and the accurate diagnosis. So this is the computed tomography image demonstrating the tennis ball sign. So this one image shows the type A dissection, and the second image is representative of the type B dissection. Now, computed tomography. Computed tomography remains the first line imaging for definitive diagnosis of aortic dissection. It is readily available in the most hospital and allows for characterization of the type, position, and the size of dissection alongside the identification of potential differential diagnosis. For example, pulmonary embolism. However, unlike echocardiography, it requires transfer of the patient and thus may not be immediately possible in the patient. The preferred protocol is the non-enhanced CT followed by the contrast-enhanced CT angio. To assess the full extension of the dissection, the scan should extend from the chest wall the way down to the pelvis. The presence of visible dissection flap has previously been described as tennis ball sign. Now, point of care ultrasound. Echocardiography. Both transthoracic and the transesophageal echocardiography can be utilized in the diagnosis of acute aortic dissection. Their ability to rapidly diagnose aortic dissection at the bedside is potentially life-saving. Transthoracic echocardiography has the advantage of being less invasive than the transesophageal echocardiography and more readily available. Also, transesophageal echocardiography is impractical in patients with symptoms, even if sedation is employed, and making it less so favorable imaging modality at the stage of diagnosis. So, transesophageal echocardiography is usually used in the operating room after induction of anesthesia if surgery is warranted, and sometimes in the ICU if the patient is intubated and ventilated. Both modalities allow for visualization of aortic valve, aortic root, ascending aorta, and the pericardium. Use of suprasternal echocardiographic window will also allow for visualization of arc of aorta. It is, however, important clinicians acknowledge that while echocardiography may rule in dissection, it should not be used to rule out one. Echocardiography finding in aortic dissection, that is dissection flap. A mobile linear echoic line separating true and false lumen. Then aortic valve disruption. Aortic regurgitation may be seen if dissection extends to the aortic valve. Then pericardial fluid. Visualized as the anechoic fluid in the pericardium sac. Aortic root dilatation. Index to height according to the BSc guide. Then the regional wall motion abnormality. Areas of regional wall motion abnormality depending on the coronary territory if affected by the dissection. Now abdominal aorta scan. Ultrasound examination of the abdomen allow for the identification of an aortic dissection extending down the abdominal aorta. The aorta is examined in the transverse and the longitudinal section, with typical appearance being the presence of the flap or thin membrane fluttering within the vessel. Color flow Doppler can also incorporate it to ascertain for presence of flow through the false loop. When combined with the echocardiography, this technique has been quoted to have sensitivity of 67% to 80% and specificity of 99% to 100% for diagnosing aortic dissection. No literature currently exists describing a method to accurately differentiate acute from the chronic aortic dissection using ultrasound. Now about magnetic resonance imaging. Magnetic resonance imaging has a high sensitivity and specificity for detection of aortic dissection. The use of MRI is limited by its availability, prolonged scan time, challenges associated with monitoring, and contraindication in patients with metal implant such as pacemaker. About ECG, aortic dissection may result into the abnormal ECG finding which can distract the clinician. More than 70% of the patients with type A aortic dissection have an abnormal ECG. The previous studies have demonstrated that type A aortic dissection may present with following. That is ST elevation. This is closely related to the direct coronary involvement. ST depression in 34% and T-wave changes in 21%. Presence of ECG changes are associated with increased incidence of shock and the cardiac tamper. It is thus important aortic dissection remains on the differential list in such a cases and is not brushed aside by tunnel vision pursuit of myocardial infarction. Chest X-ray. Traditional teaching emphasize the presence of widened mediastinum in patients with type A aortic dissection. It is, however, important to recognize that more than 20% of patients with type A dissection do not have this finding, and it should therefore not be used as a rule-out investigation. Cardiomegaly may also be present in cases of pericardial effusion or aortic valve incompetence secondary to the aortic dissection. Now about biomarkers, biochemical marker, much work has been done to try and identify biochemical marker of aortic dissection. D-dimer is one such a biomarker. Meta-analysis assessing its use in the diagnosis of acute aortic dissection found a D-dimer of more than or equal to 500 mg per ml to be associated with 97% sensitivity and 56% specificity. This corresponded to the negative predictive value of 96% and the positive predictive value of 60%. The result highlighted the potential role for D-dimer in identifying patients without aortic dissection. However, the role of biomarker is significantly limited in the acute scenario where time cannot be afforded to waiting for result, and thus they are likely useful only as a rule-out tool in the potential chronic presentation. Now about aortic dissection management. About initial management. When managing acute aortic dissection, initial treatment should concentrate on resuscitation and stabilization of the patient while deciding and preparing for definitive intervention. The overriding goal of initial management is to reduce shear forces being placed on the aorta while ensuring sufficient organ perfusion. So about blood pressure management. Tight blood pressure control and the reduction of the rate of pressure rise during systole is vital to reduce the chances of dissection propagating further. The shear force within the aorta is defined by change in the pressure over time. The rate at which intimal tear propagate is associated to the change in pressure over time, thus highlighting that simply dropping blood pressure is not sufficient. So this demonstrated the arterial waveform and the effect of pharmacological agent. This first image is baseline arterial form, where DP pressure over time represents the shear forces, which is a result of change in pressure over time. Then second image is showing the background light rate line. It is the baseline arterial waveform, and the superimposed green line is the waveform after the use of vasodilator, leading to reduction in the arterial pressure but increase in the heart rate and pressure over time. Again, in third light red line is the baseline arterial waveform, and the purple line represents the waveform following the beta blocker treatment, leading to the reduction in the blood pressure, heart rate, and with this is the reduction in the pressure over time. So if you look at figure 5, the purple line represents the addition of vasodilator in isolation. And here the systolic and diastolic pressure have dropped and the pressure over time has increased. Secondary to the reflex chronotropic and inotropic response. The image 2, the addition of beta blocker has lowered the heart rate and thus decreased the pressure over time. In case where there is a different blood pressure between the limb, the higher blood pressure should be treated. So in the absence of aortic regurgitation, the first line antihypertensive agent is beta blocker, targeting the heart rate of 60 to 80 beats per minute, systolic blood pressure of 100 to 120 mmHg. The primary drug choices and example regimen include Ismolol, that is a loading dose of 200 microgram per kg per minute, is given, followed by the infusion of 50 microgram per kg per minute for 4 minutes. Further loading doses and increased maintenance dose may be used as required. Labetalol initial bolus of approximately 0.25 mg per kg with further boluses at 10 minutes interval as required. Once blood pressure is adequately controlled, an infusion can be started. Metoprolol given as a bolus of 5 mg repeated at 5-minute interval if required to 15 mg. Although labetalol is frequently used for the blood pressure control in this clinical setting, it should be borne in the mind that drug has an elimination half-life in the excess of 4 hours and that changes in the rate of infusion will not yield steady-state plasma level for 16 to 20 hours. Despite labetalol popularity, it is a singularly unsuitable for minute-to-minute blood pressure control. In patient intolerant of beta blocker, non-dihydropyridine calcium channel blockers such as diltiazem or viramfamine are acceptable alternatives. The use of vasodilator may also be required to aid rapid blood pressure control. This includes sodium nitrochloride given as an infusion titrated to the effect at 0.5 to 1.5 microgram per kg per minute, and the glyceryl nitrate given as an infusion titrated to the effect at 2 to 10 mg per hour. Both sodium nitrochloride and the glyceryl trinitrate may produce reflex tachycardia that can exacerbate myocardial ischemia. Now about surgical treatment of aortic dissection. About type A dissection, surgery is the standard treatment for acute type A aortic dissection. The basic principles are to resect primary tear, establish the blood flow in the true lumen, and replace the dissected intrapericardial aorta. Surgery should generally be undertaken as soon as possible after the diagnosis. About type B dissection, the first line treatment of the type B dissection is the medical management, control of blood pressure and analgesia. Approximately 90% of type B dissection can be managed in this way in the acute. However, intervention is required if the type B dissection is complicated. Complicated type B dissection is characterized by persistent refractory pain. This indicates the risk of impending rupture, bowel, or visceral ischemia and should be considered as one of the early features for intervention. Then malperfusion. In type B dissection, malperfusion may be dynamic or fixed. Depending on the vessel involved, the presentation can vary. The patient presents with the acute abdominal pain, distension, or acute limb ischemia. Rupture or leak. A leak can be usually identified on the CT scan but may be present as persistent or non-resolving pain. Rapid aortic expansion and dilatation. To assess for this, repeat CT is done 48 hours after diagnosis and earlier if any signs of complications are present. Then post-op care analgesia. The extent of operation means the significant analgesia is required to ensure the patient can mobilize and ventilate adequately. Multimodal analgesia should be investigated. Then patient may benefit from the epidural catheter insertion, but it is important to maintain balance between sensory and promote and motor blocks. So the analgesia can be maintained while permitting mobilization. Now, therapist input. The main post-op physiotherapy priorities are the prevention of secondary respiratory complication, early rehabilitation, and non-pharmacological management of delirium and education. About respiratory post-op pulmonary complication are frequently reported following aortic dissection repair. Between 15% and 55% of patients develop acute respiratory dysfunction post-operatively, leading to increased number of days requiring mechanical ventilation and longer ICU length of stay. Physiotherapy aims to reduce incidence of this post-op complication by increasing lung volume, receiving secretion, and reducing work of breathing. The beneficial effect of early mobilization in mitigating complication following cardiac surgery have been well established and are considered standard practice within cardiothoracic critical care. Early mobilization should be the first line post-op rehab approach unless contraindicated. When early mobilization is not permitted, further strategies can be utilized, including optimization of the patient's positioning, mechanical insufflation and exsufflation, and non-invasive ventilation. Now about rehabilitation. In elective cases, the patients are ordinarily reviewed in the pre-assessment clinical whether pre-surgical functional status can be determined. The use of outcome measures such as clinical frailty score aids the identification of patients at higher risk of reduced functional ability post-operative. For non-selective cases, this is often not possible and communication with the patient, next of kin and family are vital to establish functional baseline. Family and the friends play an important role in the rehabilitation process and should be provided with regular update and involved in the rehabilitation as much as possible with consideration of the patient's wishes. Rehabilitation in the critical care is provided following comprehensive individual assessment by physiotherapists with formation of rehabilitation plan and the patient's oriented goal. Exercise in the critical care includes sitting on edge of the bed, sitting out of the bed using appropriate method of transfer, and walking with assistance or aid. More advanced rehabilitation is administered once patient improve to standing and walking unaided or new neurology has been identified. Assessment of the patient in the critical care occurs within 24 hours of the admission, and thus physiotherapists are in the prime position to detect any new neurological symptom. Spinal cord infarct is the rare and the serious complication following aortic dissection repair and occur every in 130 patients. Management of patient with spinal cord infarct following surgical repair will differ from the management of post-operative dissection, and this has not been discussed in detail here. Post-operative cerebral complications are common post-operatively and include new onset stroke, syncope, delirium, coma. Where post-operative cerebral complications have been identified, individualized rehabilitation plan and the patient's orientation goal are set alongside specialist referral. So the physiotherapists play an important role in the non-pharmacological management of the delirium. This includes early mobilization, daily orientation, engagement with family member, spontaneous awakening and the breathing trial, sleep promotion, daily assessment of the delirium using tools such as confusion assessment method. About patient education, in addition to the respiratory care and the rehabilitation, physiotherapists promote healthy lifestyle changes through education and referral to the appropriate service. This includes smoking cessation and providing guidance on exercise and lifestyle choices to promote recovery and prevent further complications post-op. This is the algorithm of management of the aortic dissection. Suspected aortic dissection, initial stabilization, first head-to-toe assessment, wide bore IV access or blood, invasive BP monitoring and tight BP control, ensure adequate analgesia, then diagnostic making, bedside echocardiography, if skill set available and unsafe for transfer, city safe for transfer, then communicate with the surgical team whether intervention is required or not. If type A, if the dissection is type A, then we have to go for surgical management. If type B dissection, if it is complicated, surgical management. If it is uncomplicated, medical management. Complicated type B dissection criteria is persistent refractory pain, malperfusion, rupture of the leak, rapid expansion of false lumen. Thank you, guys.